Hi, my name is Lauren Wen, and I'm a second-year medical student at the University of Washington, and I'm pleased to present this research on behalf of my colleagues. My colleagues and I have no financial conflicts of interest to disclose. This research is on the transition of care from the emergency department for patients with opioid use disorder who receive buprenorphine. Opioid use disorder, OUD, and opioid overdose deaths have dramatically increased over the past 10 years, with opioids accounting for almost 70% of all drug overdose deaths in 2018. And with this increased use of opioids has come an increased use of the ED for OUD, which research has shown to be an effective environment for buprenorphine initiation. For example, the 2015 JAMA article by D'Onofrio and colleagues showed us that patients with OUD who are seen in the ED and receive buprenorphine have improved retention and addiction treatment at 30 days. However, real-world implementation of this practice requires an outpatient clinic that can receive these patients and can continue buprenorphine management. So that's where a transitional care clinic, such as the aftercare clinic at Harborview Medical Center, can come in to potentially provide an effective linkage to ongoing outpatient buprenorphine management for patients who receive buprenorphine in the ED. The aim of this study is to describe potential barriers and facilitators to attendance and correlates of attendance at the Harborview Medical Center aftercare clinic for patients who receive buprenorphine in the ED. Methods. This study was a retrospective study of all adult participants who were prescribed or dispensed buprenorphine in the Harborview Medical Center ED from June 1st, 2019 to June 1st, 2020. A total of 146 patients were included. You can see the inclusion and exclusion criteria listed here. Of note, patients were only included if they were discharged from the ED to the community, meaning that if they were discharged from the ED to anywhere other than the community or admitted as inpatient, they were not included in this study. Both patient and visit level characteristics were abstracted from the EMR, and then double abstraction of hand abstracted variables was performed on 20% of charts for reliability. Statistical methods included descriptive statistics and adjusted logistic regression to predict attendance at aftercare within 14 days of the index ED visit. I'll take us over to results. First, we'll start with Table 1, characteristics of patients referred to aftercare stratified by aftercare outcome. In the leftmost column, we see a host of different patient characteristics that we studied. In the column to the right, we have all aftercare referrals, again, 146 patients. Then to the column in the right, we have patients that did not attend their visit, about 70% of the sample. And then in the column to the right, we have patients that did attend their visit, about 30%. And in the rightmost column, we have p-values. What I want to highlight in this table are the characteristics that were shown to be statistically significantly different between the group that attended their visit versus did not attend their visit. So those characteristics included being unhoused, not owning a cell phone, and having a positive history of incarceration. These three characteristics were all shown to be statistically significantly different between the group that attended versus did not attend their visit. And we further analyzed our data through logistic regression. So that takes us to Figure 1, adjusted correlates of attendance at aftercare. On the y-axis, we have patient characteristics that we studied. Then on the x-axis, we have adjusted odds ratios. And again, I'll just highlight the odds ratios that were shown to be statistically significant. First, being unhoused and attending the aftercare visit had an odds ratio of 0.32 with a 95% confidence interval of 0.12 to 0.86. And then a few lines down, we can see incarceration. Having a positive history of incarceration and attending the aftercare visit had an odds ratio of 0.28, confidence interval of 0.1 to 0.77, showing that these two characteristics had a negative association with aftercare attendance. So for our discussion, what this data shows us is that patients in the ED with OUD who receive buprenorphine have several social risk factors, including housing status, employment status, and incarceration history. The majority of our sample was unhoused, not employed, and had a positive incarceration history, outlining the difficulties that may impede continued outpatient OUD management. So in conclusion, the aforementioned social risk factors may present barriers to post-ED follow-up care for patients with OUD. So future programs should screen for social risk factors to assist with a more successful transition to outpatient buprenorphine management. Understanding these social risk factors may improve retention and treatment for this vulnerable population. I'd like to acknowledge the funding that supported this research with the award numbers listed below. Thank you so much for your time.
Hello everyone, I'm Tiffany. research coordinator under Emergency Department of Baylor Scott and White Olsen's Medical Center. Our study is alternative to opioids, Alto protocol in acute pain management emergency department during COVID-19 pandemic. There was no conflict of interest in our study. With more than 750,000 people have died from drug overdose since 1999, there were over 70% deaths of drug overdose in 2019 involved opioid use. Therefore, the alternative to opioids, Alto protocol was developed using targeted non-opioid medications to tailor patients' pain management needs and avoid opioid use whenever possible. This is the first study for Alto protocol implementation for pain management in the emergency department. So according to different causes of pain, physicians would offer patients different non-opioid medications according to this protocol. And they found that the opioid use was significantly reduced with Alto protocol implementation from 1.45 to 1.13 mmorphine equivalents per patient visit. In addition, during COVID, there was 1,000% increase in emotional stress distress reported to emergency hotlines. Also, in Erie County in New York, there were 85 people died from opioid overdose during the first 4 months of 2020, which was 100% increase from that period last year. But given that emergency departments have been identified as the starting point on a patient's path to the opioid addiction, our research goal was to investigate the impact of the Alto protocol on opioid use for acute pain management under emergency department setting during COVID-19 pandemic. Our study is a single-center retrospective cohort study with annual ED volume around 50,000 patients. We collected the data among March to August in 2019 and 2020 to evaluate the opioid and Alto medications use between pre-COVID versus COVID times. Opioids and Alto medications were all converted to mean morphine equivalents, MME, for data analysis. For primary outcome, we evaluated the change in opioid administration, and for secondary outcome, we evaluated Alto medication change of the administration and patient satisfaction to pain control, admission rate, ED length of stay, and the rate of left without being seen. So our study enrolled around 23,000 patients in 2019 and around 17,000 patients in 2020. And we found that the opioid use was reduced by 59.1% among discharged ED patients during COVID-19 pandemic. And also, there was no significant difference in opioid use during pandemic, which remains low with the Alto protocol implementation. Also, for the Alto medications, we noticed significant increase in acetaminophen use, decrease in NSAIDs and ketamine use. But overall, there was no significant difference for non-opioid Alto medication use. For other secondary outcomes, like patient satisfaction, admission rate, ED length of stay, and left without being seen rate, there was no significant difference during COVID-19 pandemic. This is another study noted the increased opioid overdose during COVID-19 from emergency medical services data. However, there was still limited other study for the evaluation of opioid overdose during the COVID-19 times. Our study limitations included single center study, and also the design was a retrospective observational cohort study. So from our study, we can learn that during COVID-19, the Alto protocol can keep low opioid use at emergency department setting. Also, it can reduce opioid prescription among ED discharged patients. And we will need to warrant further research for this topic to see the tendency of the opioid use and the auto medication use. Thank you so much.
Good afternoon, everyone. My name is Christine Ramzan, and I'm a research associate with the Department of Emergency Medicine at Rutgers, New Jersey Medical School, affiliated with University Hospital. I graduated with a PhD in biomedical informatics in 2018, and I have research interests in pain management and addiction. My faculty mentor for this project is Dr. Lewis Nelson, who is the chair of the department and also a board certified medical toxicologist. The title of my project is NSAID use in an urban emergency department during New Jersey's first wave of the coronavirus pandemic. I have no disclosures, neither of us have any disclosures. This project was inspired by the growing concerns at the beginning of the pandemic that use of NSAIDs in patients that were positive for coronavirus can result in adverse effects. On March 19th, the FDA posted guidance stating that there was no scientific evidence that demonstrates that use of NSAIDs can cause adverse effects in patients that are positive for COVID. However, they also do state that for those that who wish to use treatment options other than NSAIDs, there are multiple over-the-counter prescriptions that could be used for pain relief alternatively. Later throughout the year, multiple studies were published, including one from the World Health Organization, indicated that there was in fact no evidence of severe adverse events coming from use of NSAIDs in coronavirus positive patients. Consequently, the objective of our study was to determine if early concerns of NSAID adverse events caused a decrease in NSAID utilization in our emergency department during our first wave. In order to carry out this project, we conducted a retrospective review of our hospital pharmacy records of all analgesics administered within the time frame March 1st, 2020 and May 31st, 2020, which represented the approximate time frame of which New Jersey had its first wave of coronavirus. We compared the data from this time period to the corresponding time period in 2019. For simplicity, we have abbreviated both of those timeframes as T19 and T20 respectively. We computed the administration of the rate of administration of parenteral and oral analgesics, acetaminophen, NSAIDs, particularly ibuprofen and ketorolac, since those are most commonly used, as well as most commonly used opioids such as hydromorphone, morphine, oxycodone, fentanyl, and tramadol. We normalized all these rates we computed these rates by using ED volume, normalizing true ED volume, and we used the chi-squared difference of proportions test to compare rates. We found that comparing T19 and T20, there was overall a decrease in the rate of analgesic administration, as well as decrease in use of parenteral analgesics, which essentially indicated that we possibly saw less sicker patients during the first wave of coronavirus compared to the previous year. We found that acetaminophen administration increased from 13.3% to 15.2%. We found that opioid administration decreased from 10.3% to 7.2%, which could have been a consequence of our guideline. And we did find that NSAID administration actually did decrease in our department from 21.6% to 13.3%, specifically use of ketorolac and ibuprofen. In figure 1, you can see these numbers a little bit more clearly. You can see that NSAID administration dropped almost 8%. An opioid administration decreased as well, and acetaminophen administration increased, and all these figures, all these numbers were statistically significant, all these changes. So overall, our results show that there was a decrease in administration of NSAIDs during the first wave of the coronavirus pandemic in the ED. It appears that use of NSAIDs was replaced by use of acetaminophen, although the relationship between those two is not very clear. We also saw that there was a decrease in use of opioids, which could have been due to our pain guideline. So our study did not stratify patients by chief complaint and acuity level. Future studies should focus on determining whether the findings from these studies are consistent across EDs nationwide, and they should explore the reasons for these changes and what the reasons are in relationship to COVID. If found to be COVID related, a review of educational and messaging messages about COVID and NSAID use should be warranted. Thank you.
Good morning, everyone. My name is Gina Jacob, and I am an assistant professor at Rutgers, New Jersey Medical School. And today I will be presenting my poster, Evaluation of a Guideline to Reduce Opioid Administration in an Urban Emergency Department. So introduction. We're all aware of the magnitude of the opioid crisis in the United States, and emergency physicians have the opportunity to mitigate this crisis through the judicious opioid ordering and administration in the ED. There is growing evidence that NSAIDs and acetaminophen are safer alternatives to opioids and provide sufficient analgesia. RED developed guidelines in March of 2018 recommending NSAIDs and acetaminophen over opioids as initial agents for the management of acute abdominal pain. Our study hypothesis was that opioid administration and ordering in the ED would decline after the institution of these guidelines. Methods. We performed a search of our electronic health record for adults greater than or equal to 18 years old with a discharge diagnosis of abdominal pain from January to June 2017 and from January to June 2019, that is pre and post guideline. We randomly selected 175 patients from each period. The primary endpoints of our study were the number of opioids, acetaminophen, and NSAIDs administered as first-line analgesics, and overall opioid administration in the ED. Secondary endpoints were the number of patients requiring subsequent rounds of analgesics, repeat ED visits for the same concern within 7 days, patients receiving any analgesic prescription at discharge, and prescriptions for opioids at discharge. Our results. So on our table, you will notice that there's a pre-guideline and a post-guideline column with an N of 175 in each group. The percentage of patients receiving opioids overall decreased between the pre and the post-guideline study period, decreasing from 16.6% to 7.4% with a P of 0.004. Similarly, opioid administration and ordering as a first-line agent decreased pre and post guideline, decreasing from 13% to 6.9% with a P of 0.025. The ordering and administration of acetaminophen first line increased between the pre and the post guideline study period, increasing from 9.7% to 24%. With a P of 0.002. There was an increase in the ordering and administration of NSAIDs first line, but this was not statistically significant. Pre-guideline, it was 24%, and post-guideline, it was 30.9%, but the p-value was 0.075. There was also a statistically significant decrease in opioids prescribed at discharge. This was 8% pre-guideline and 0.6% post-guideline with a p-value of 0.0004. There were no significant differences in patients receiving NSAIDs first line, subsequent rounds of analgesics, any analgesic prescription at discharge, and repeat ED visits for the same concern. So conclusions are, the implementation of guidelines for the treatment of abdominal pain was associated with a decrease in ED opioid administration and opioid prescriptions. There was not an increase in the subsequent rounds of analgesia administration or repeat ED visits for the same concern within 7 days. Future research should focus on the use of opioid-sparing guidelines for the treatment of other types of pain and use in other populations. Thank you.
Hello, my name is Irvan Bubic. I'm a first-year emergency medicine resident at the University of California, San Diego. The title of our poster is Efficacy of Bedside Nerve Block for Acute and Chronic Pain Performed in the Emergency Department, a Cross-Sectional Study. And I worked on this study with Dr. Jessica Oswald. In terms of background, we know that pain is a leading cause of emergency department visits, and we also know that untreated acute pain has been shown to frequently transition to chronic pain. We had a few objectives for this study. So we have this mobile ED or MED pain management team, which consists of a double board certified pain management and emergency medicine provider, and also the emergency medicine residents. And we performed a variety of procedures for acute and chronic painful conditions. And we took that data and evaluated the educational value of this team, the primary ED provider satisfaction, and also the procedural efficacy of having a dedicated pain management team. In terms of methods, it was a cross-sectional study performed in one academic emergency department last year in October of 2020 to November of 2020. In terms of population, we looked at adults with a variety of both acute and chronic painful conditions who received bedside nerve blocks in the emergency department. Data collected included the procedure indication, pre and post visual analog scale pain scores, as well as provider observations in change in function, mobility, and mood. And then we also got surveys from the pain team, the providers and the residents in terms of satisfaction with their experience. Regarding results, the average 30-minute post-procedure VAS pain reduction was 67%, and observed improvement in pain, function, and mood, so from the provider's perspective, was 65%. The most common procedure performed was the erector spinae nerve block, with an average 30-minute VAS pain reduction of 74% and observed improvement in pain, function, and mood of 71%, again, from the provider's perspective. A 100% 30-minute VAS reduction was observed for the following blocks. So the erector spinae block performed for renal colic, trigger point injections to the head and neck muscles performed for whiplash pain, and also bilateral greater occipital nerve blocks for post-concussive syndrome. In the top right of the poster here, you can see in the first column, there's the type of block, the indication, and then the percent change in the visual analog score, scale score at 30 minutes. So for the erector spinae block, kind of like I mentioned earlier, when performed for axial low back pain, we saw a 71% change in the VAS score. When it was performed for renal colic, it was 100% reduction. When it was performed for chronic pancreatitis, we noticed a 50% reduction in the VAS pain score. The rest of these nerve blocks also have a variety of pain reduction scores. So we performed genicular nerve blocks, which you can actually see in this picture in the middle column, which resulted in an 88% change in VAS score. That was performed for a tibial plateau fracture. An inferior alveolar nerve block for a submandibular abscess resulted in 56%, and so on. You can go down this chart and see the indications, the nerve block, and then the resultant change in VAS score at 30 minutes. Of course, this study is limited at this time, so it's ongoing. We have a very small sample size at the time of this poster, and as such, it's kind of hard to extrapolate this into and generalize this into any data that we can use in the emergency department at this time. It was retrospective, and also the pain management team is led by a dual board certified EM and pain management physician, which may make it slightly more difficult to generalize this data for the average EM doctor. However, in conclusion, we did notice that overall, bedside nerve blocks performed in the emergency department resulted in an average pain reduction of 67% at 30 minutes on a 10-point visual analog scale. Of course, we don't have any statistical significance for this number at this time, and we definitely need some more data before we can make that claim, but I'm excited to see where this study takes us. Thank you very much for listening to my poster, and I welcome any questions you have.
Hello, my name is James Krenz, and I am a second-year emergency medicine pharmacy resident at Massachusetts General Hospital. Today, I will be presenting on dexmedetomidine continuous infusions in the emergency department to facilitate medical care in the agitated patient. Dexmedetomidine is an alpha-2 agonist that is often used as a sedative agent for patients who are mechanically ventilated. Dexmedetomidine can produce light sedation without decreasing respiratory drive. And because of this, clinicians have recently become interested in utilizing dexmedetomidine to facilitate medical care in the agitated patient population. Dexmedetomidine is mentioned in the 2017 American College of Emergency Physicians position statement as an option for procedural sedation. Despite this, however, most literature regarding the use in adult patients in the emergency department is limited to case reports. The purpose of this project was to evaluate and characterize the use of dexmedetomidine continuous infusions to facilitate medical care in the emergency department setting. The primary outcome was successful facilitation of medical care or control of agitation. Secondary endpoints included dexmedetomidine dosing, infusion duration, ED length of stay, as well as sedative agents that were received before and during dexmedetomidine infusions. For safety endpoints, we evaluated the incidence of bradycardia, hypotension, and hypoxia. This was a retrospective descriptive analysis of patients who received dexmedetomidine in an academic emergency department between February 2018 and July of 2020. We included all patients who were age 18 years or older who received dexmedetomidine either to facilitate medical care or for control of agitation. Patients that received dexmedetomidine for other indications were excluded from this analysis. The baseline characteristics of our patients can be seen in Table 1. In Table 2, we have the characteristics of dexmedetomidine infusions. In total, we had 35 patients that were included in this study. Our median initial infusion rate was about 0.2 micrograms per kilogram per minute, with a median maximum infusion rate of 0.5 micrograms per kilogram per minute. We had 7 patients who received a loading dose of dexmedetomidine with a median bolus dose of 1 microgram per kilogram. The median infusion duration was approximately 3 hours. In terms of indications for dexmedetomidine continuous infusions, we had 22 patients who received dexmedetomidine to facilitate computed tomography imaging. We had 13 patients who received dexmedetomidine for agitation alone. In terms of our outcomes, of our 35 patients, 30 patients had dexmedetomidine used successfully to either facilitate medical care or to control agitation. Of our 30 successful cases, 21 of those cases were cases in which dexmedetomidine was utilized to facilitate medical care, and then 9 cases in which dexmedetomidine was used to control agitation. We had 4 patients who required intubation for ongoing agitation despite dexmedetomidine and other sedative therapy, and we had 3 patients who had a narrative account in their medical record of failure to facilitate care despite dexmedetomidine infusion. We did have 2 patients who had both a narrative account of treatment failure as well as the need to be intubated for ongoing agitation. In terms of sedative agents, most patients received dexmedetomidine infusions after benzodiazepines or antipsychotics, and we had 7 patients who received dexmedetomidine after ketamine. In terms of sedative agents that were received during dexmedetomidine infusions, most patients did not require any additional sedative agents after the initiation of dexmedetomidine. Those that did receive sedative agents mostly received antipsychotics or benzodiazepines. We had 7 patients that experienced bradycardia, 4 that experienced hypotension, and 2 that experienced hypoxia. This study was limited by its small sample size, single center, as well as retrospective design. Despite this, dexmedetomidine continuous infusions in the emergency department were associated with successful facilitation of medical care or agitation control in most patients. Dexmedetomidine, as I mentioned, was most often administered after other sedative medications had been trialed, and the amount of sedative agents administered decreased after initiation of dexmedetomidine continuous infusions. The most common adverse events seen in this study were bradycardia and hypotension. Larger studies are likely needed to further determine the role of dexmedetomidine in facilitating medical care and controlling agitation in the emergency department setting.
All right, hi everyone. My name is Alex Anchius. I'm one of the second years here at UCSD, and I did this project with Dr. Jessica Oswald, who is trained in both emergency medicine as well as anesthesia pain management. And our project was called Erector Spinae Plane Block, a new option for managing acute axial low back pain. So a little bit of background. As we know, acute low back pain is one of the most common reasons patients present to the emergency department, and it's often difficult to treat. The Erector Spinae Plane Block is a perioperative regional block used to treat thoracic, rib, spine, and abdominal wall pain. While it is used for postoperative pain control for spine surgery, there's limited evidence to support its use in treating acute axial low back pain in the emergency department. So for our objectives, we wanted to evaluate outcomes of 6 patients who presented to the ED with acute onset of severe low back pain, who were then treated with an ESP block. And as far as our methods, this was a case series, again, of 6 patients aged between 27 and 64 who presented with severe atraumatic low back pain, which appeared musculoskeletal in origin, who were then treated with a lumbar ESP block in the ED. Our procedures were performed in the prone position. The location for the procedure was chosen by a point of maximal tenderness in their paraspinal muscles. We used both the linear and curvilinear probes in this project. And then we used a 3.5-inch blunt tip 23 gauge spinal needle, which was inserted in plane in the caudocranial direction. And as you can see here with this image, you can see the needle tip being advanced in plane with the ultrasound, advancing down here to the target, which would be the transverse process. You want your needle tip to actually touch the transverse process. And after you aspirate, you then inject about a cc of normal saline to confirm your location. You should then see the erector spinae fascia dissect posteriorly off of the transverse process. And once you see this, you'll then inject 20 cc's of 0.25% bupivacaine, and you will then see both cranial and caudal spread of that medication. So the results of our study were that the visual analog scale pain score reduction ranged between 71 and 100%, with an average of 81.8%. The average length of stay prior to the ESP block was 225 minutes, and after the ESP block was 73.5 minutes. 5 out of 6 patients did not have any return ED visits for back pain. All 6 patients required no post-procedure opiates in the ED or after discharge. And 2 of the 4 patients that we contacted, we were able to contact post-discharge reported pain relief, which lasted longer than the anesthetic half-life, which has been seen in other studies. And then here on this table, you see a little bit more details about each individual patient. You see the pre and post-procedure pain scores, percentage pain reduction, length of stay prior to the block and after the block, medications given prior to the block, and the spinal level at which we perform the procedure. As far as something to note with medications, as you can see, the majority of patients only received a lidocaine patch prior to the procedure. However, this patient received several medications because he came in with refractory low back pain. He was not ambulatory and he was likely going to be admitted, but thankfully after the procedure was able to ambulate out of the ED. So in conclusion, the ESP block is a promising technique that gives us emergency physicians a rapid, safe, and opiate-sparing option for the treatment of acute low back pain. ESP blocks can result in decreased pain, length of stay, decreased opiate requirements, and decreased admission rates for refractory low back pain. So just something to consider when you have a patient who has what seems to be acute musculoskeletal low back pain. Perhaps they were lifting something up, or they were more active than usual, or just heavy lifting in general. And lastly, limitations. Obviously, this is a case series with only 6 patients, so a small sample size. And then there was limited follow-up. We were only able to get a hold of 4 of the 6 patients after discharge. And this was at varying times. So it would have been better if we were able to contact them a week or a month or several months after discharge to see how their pain, how long their pain control lasted. So that's all I have for you. Thanks so much.
Hi, everyone. My name is John White, and I am the current PGY2 Emergency Medicine Pharmacy resident at the University of Colorado Hospital. Today, we'll be talking about a prospective assessment of patient satisfaction with ketamine for pain in the emergency department. Generally accepted doses of ketamine for pain include 0.1 to 0.3 milligrams per kilogram, compared to doses exceeding 1 milligram per kilogram, which are associated with dissociative effects and frequently used for rapid sequence intubation and other procedural sedations. Clinical effects of doses in between these ranges are not well described, but presumably associated with more adverse effects than would be expected with the generally accepted pain doses. While higher doses, such as 0.3 milligrams per kilogram in this pain dose range, have demonstrated improved efficacy over lower doses, an increase in adverse events was also noted over lower doses. Additionally, patient satisfaction with various pain doses of ketamine has yet to be assessed, an important gap in literature, as patient acceptance of ketamine as a treatment modality for pain will heavily influence future use. The purpose of this project was to assess patient satisfaction with ketamine at various doses for acute pain in the emergency department. This was a single-center, prospective observational study, including adult ED patients receiving a standard pain dose of ketamine. All pain indications were included, and any patient receiving ketamine for anything other than pain, including procedural sedations, were excluded. Patient satisfaction, assessed via a standard phone survey after discharge from the ED, was the primary endpoint. A 1 to 7 Likert scale was used to assess satisfaction with pain control in the ED and likelihood that they would request ketamine for pain in the future. Secondary endpoints assessed included efficacy endpoints, such as opioid requirements prior to and during the study period, as well as a reduction in patient-reported pain scores over time following administration of the ketamine. Safety was assessed through patient-reported adverse events. Endpoints were evaluated based on ketamine dose, with the low dose comprised of those who received less than 0.2 milligrams per kilogram of ketamine, and the high dose anyone who received 0.2 milligrams per kilogram or greater. Overall, 18 patients were enrolled in the low-dose ketamine group and 8 in the high-dose group, a difference that likely resulted from changing provider perceptions favoring lower doses of ketamine for pain as the study evolved. Demographics were similar between the low-dose and the high-dose ketamine groups. However, there was a non-significant trend towards more patients in the low-dose group receiving ketamine for musculoskeletal pain. Patient satisfaction with ketamine for pain was not significantly different between the low-dose and high-dose groups. Median opioid requirements were significantly higher during the study period in the high-dose group compared to the low-dose group, at 12.6 versus 0 morphine milligram equivalents, suggesting these patients were possibly treated more aggressively with either ketamine, opioids, or both for perceived pain. This theory, however, is contradicted by the fact that the patient-reported pain scores at baseline were approximately 1 point higher in the low-dose ketamine group compared to the high-dose group, a difference that was statistically significant. Following administration of ketamine, mean pain scores were not significantly different at any time point between the low and high dose groups. Within each group, pain scores over time did not differ significantly compared to baseline values following administration of ketamine. While numerically more adverse events occurred in the low-dose ketamine group compared to the high-dose group, the difference was not statistically significant. Additionally, there was a non-significant trend towards increased very bothersome adverse events in the high-dose ketamine group. A significant limitation of the study is the potential missed enrollments due to convenience sampling. Study enrollment only occurred if the ED pharmacist currently staffing had the time to prospectively assess the patient for inclusion and exclusion criteria and administer the enrollment questionnaire and consent form in real time. An additional limitation is the dose distribution, heavily favoring the low-dose ketamine group, possibly driven by provider perception of increased adverse events with higher doses of ketamine. Additional enrollment, particularly in the high-dose group, may have provided further power to detect differences between the primary and secondary endpoints. Finally, response bias from our satisfaction surveys, likely favoring those who had a good experience with ketamine, is a factor that's difficult to fully account for, but likely present to some degree. To conclude, higher doses of ketamine for acute pain management in the ED were not associated with increased patient satisfaction, pain control, or reduction in opioid requirements. This, coupled with historical evidence of increased adverse events with escalating doses, may help provide additional rationale for lower doses of ketamine for pain. Thank you for your time, and I'll gladly take any questions. I've also included my contact info for those who have questions following the Q&A.
Hi, everyone. My name is Emily Porter. I'm currently the emergency medicine pharmacy resident at UMass Memorial Medical Center in Worcester, Massachusetts. And thank you for visiting my poster session today, where I'll be discussing our findings on the prevalence of direct oral anticoagulant use in ST elevation myocardial infarction patients. The authors of this study have nothing to disclose. And to give a bit of context to our research question, it's estimated that by the year 2030, 12 million Americans will have a diagnosis of atrial fibrillation or AFib. And about 80% of these patients are going to require lifelong anticoagulation therapy, with DOACs or direct oral anticoagulants being recommended as first line for prevention of ischemic stroke. In addition to stroke, unfortunately, atrial fibrillation also places these patients at risk for other ischemic events, including an increased risk of MI by as much as 55%. Now, we know that primary percutaneous intervention, or PCI, is really the preferred treatment option for patients that present to the ED with STEMI. However, the problem is that trials evaluating this revascularization strategy have excluded patients on DOACs for long-term anticoagulation. Given the paucity of data, the primary outcome of our study was to determine the prevalence of DOAC use in this patient population. To do this, we conducted a retrospective single-centered chart review of patients presenting to the ED at a regional academic medical center. To be included in our analysis, patients had to have a diagnosis of STEMI, for which they required emergent PCI, and they also had to have a DOAC listed as an active home medication. It's also unclear if DOACs would provide sufficient anticoagulation when used alone during PCI. And for this reason, we were interested in describing the peri-procedural antiplatelet and anticoagulant practices for this patient population at our institution. As a safety endpoint, we utilized thrombolysis in myocardial infarction, or TIMI methodology, to determine risk of bleeding in these patients. Over a 3-year period, there were a little over 6,300 MI activations at our institution, and of these, 1,695 were found to be STEMI activations. From this population, 32 were identified that met our inclusion criteria of being 18 years or older, presenting to the ED with a diagnosis of STEMI, taken to the cath lab for emergent PCI, with a DOAC listed as an active home medication. 26 patients were ultimately excluded due to the fact that they required a coronary artery bypass graft as a rescue procedure. There was documentation that a patient's DOAC was held prior to presentation. If a test claim for a DOAC at our outpatient prescription center was inappropriately flagged as a home medication, or if the final diagnosis was NSTEMI rather than STEMI. And this left us with a final population of 6 patients. Looking at the baseline characteristics, we see that the average age of these patients was 77 years old, and that the primary indication for DOAC use was atrial fibrillation in about 80% of patients with an average CHA2DS2-VASc score of 4. Overall, the prevalence of DOAC use in this patient population was much lower than we had been expecting, at just 0.35% of all STEMI activations at our institution over this 3-year period. All patients received aspirin, ticagrelor, and heparin prior to PCI, and this was regardless of time since last DOAC dose. During the procedure, 2/3 of patients required additional doses of heparin, while 1 patient received tirofiban. And looking at our safety endpoint of TIMI bleeding, we see that no patients met TIMI major or minor bleeding. However, 1 patient did meet TIMI minimal bleeding criteria due to a hemoglobin drop of less than 3. Additionally, there were no deaths reported in this study. In conclusion, the prevalence of DOAC use in STEMI patients was much lower than we had been anticipating. Despite all patients receiving anticoagulation therapy with heparin, there was no major safety events reported in this study. However, future larger trials are needed to further describe this patient population. I'd like to thank Irene Lee, Nicholas Servati, and Robert Moksitsky for their continued guidance support on this project. And at this time, I'd be happy to answer any questions that anyone may have.
Hi, my name is Jack Allen. I'm a PGY2 Emergency Department resident at Temple University Hospital in Philadelphia, Pennsylvania. I'm here to present my project titled Variability in Patterns of Decision-Making for Patients Admitted to Observation Status, co-authored by Claire Goucher, Joel Koshy, Dr. Crafton Schreier, and Dr. Richard Martin. Optimizing emergency department throughput is critical to patient care, patient safety, and cost effectiveness. The ED throughput timeline is broken down into 3 phases: input, in-process, and output. The in-process time, being from first physician contact to disposition decision, is most within the locus of control of the individual ED physician. Prior data analysis at the study institution has shown that in-process time remains highly stagnant despite wide input and output variability, as seen in Figure 1. Despite these overall stagnant in-process times, within the cohort of observation patients or OBS patients admitted to the hospital, there is wide intra-physician variability in the ED in-process time. Given that OBS patients are relatively hemodynamically stable and for the most part bad things ruled out, this study sought to better understand this intra-physician variability in their workup. CT scanning creates a clear delay in in-process time. One key feature of OBS patients is there is variable use of CT scans during their evaluation. It was hypothesized that judicious use of CT scanning could improve OBS patient in-process time, thereby improving overall ED efficiency, crowding, and cost of care. This study conducted chart review on 832 consecutive OBS patients admitted to a large academic tertiary referral center between November 2019 and December 2019, notably prior to the COVID-19 pandemic. Charts were abstracted from 39 individual physicians for in-process time, CT scan utilization, and in-hospital length of stay, as well as in-hospital change in diagnosis. This study utilized a particular statistical analysis, the coefficient of variation, which allowed for comparison of variability between the two groups. As seen in Figure 2, there was an overall longer in-process time when CT was ordered versus when no CT was ordered. This was about 5 hours and 3 hours respectively. Again, the coefficient of variation was increased for patients in which a CT was ordered at 23% versus 18% when no CT was ordered. This suggests slightly more variability in the in-process times among physicians in which CTs were ordered. This suggests slightly more variable decision-making speed when CT is introduced into the workup. Figure 3 demonstrates that there is no direct correlation between individual providers' in-process times when CT is ordered versus when no CT is ordered. For this means that CT use did not uniformly delay decision-making speed, but rather had a variable effect on the in-process time. Finally, Figure 4 demonstrated that for each provider, there is no correlation between their overall in-process time and the percent of patients for which a CT scan was ordered, suggesting again that CT utilization had a varying effect on in-process time rather than directly correlated with delays in disposition decision-making. From the data reviewed, it is clear that despite the non-critical, stable nature of OBS patients, there is significant variability in how workup is approached in the ED. Though it is clear from the mean in-process times that CT utilization elongates length of stay in the ED, the provider-to-provider variability in decision-making remains highly variable with or without CT scans, as evidenced by the elevated coefficients of variation for each group. There is no identifiable correlation between CT use or non-use and improved in-process time. As such, CT utilization cannot be considered a single driver in the variability of OBS patients' in-process time. Of note, there was a very low rate of discordance between admitting and discharge diagnosis in the OBS charts reviewed. This suggests, and this persisted with or without CT use in the ED, suggesting that there's high quality diagnostic accuracy with or without CT use. Moreover, very few CTs were ordered post-admission, and if so, were very rarely management changing. Though there is no clear conclusion with regards to CT use in the ED on OBS patients from this study, there are several avenues for which we can further explore. Such further avenues to look at include indications for CT use in the ED that are variable between providers, considering cost-benefit of deferring certain CTs until after admission, and reconsidering CT utilization with respect to physician productivity or other markers of physician efficiency, such as RVU per hour. Thank you for your time, and I'm happy to take any questions.
A very good morning to everyone. I'm Amina Abdul Razak, and I'm an international medical student from India. And today I'll be presenting my abstract on behalf of my co-authors and team on emerging evidence for deep brain stimulation in refractory post-hypoxic myoclonus. Managing refractory post-hypoxic myoclonus can be extremely challenging. PHM can cause debilitating functional disabilities with pharmacological options limited to benzodiazepines and anticonvulsants. Deep brain stimulation is a well-accepted treatment for movement disorders like myoclonus dystonia, Parkinson's disease, and essential tremors. Emerging case reports suggest DBS to be a viable therapeutic option for refractory post-hypoxic myoclonus. So we performed an electronic database search from Medline, Scopus, and Embase from inception until 18th October, and published case series and reports of refractory PHM were included. Pre- and post-operative unified myoclonus rating scale scores and the DBS programming parameters were compared. A total of 8 patients were identified. Mean age was about 47.3%, 47.3 plus or minus 19.6 standard deviation years, with a male to female ratio of 5:3. Cardiopulmonary arrest was of common occurrence. DBS targeting the globus pallidus internus was reported in 75% cases, one being MRI guided, thalamic ventral intermediate nucleus in 12.5%, and both globus pallidus internus and ventral intermediate nucleus in another 12.5% cases. The mean amplitude for DBS parameters was about 2.7 volts of amplitude, pulse width 18 nanoseconds, and frequency of 130 Hz. This was needed for achieving the therapeutic responses. There was 100% improvement in myoclonus at rest and about more than 70% improvement in about 62.5% cases, with the remaining 37.5% showing about 36% improvement in action myoclonus. Infection of IPG was reported in one case, and voxel-based PET analysis was used for monitoring in another case. So we conclude that a robust improvement has been demonstrated. Globus pallidus internus is the most optimal target site for DBS, and with a small cohort of published cases, it is reasonable to consider deep brain stimulation as a potential effective therapeutic treatment for refractory PHM. For technological advances like interventional MRI and PET analysis, application of DBS will continue to grow, and further studies are warranted to elucidate its efficacy and support. Thank you.
Hello, my name is Nicholas Thompson.
And my name is David Patternite.
And our study is titled Correlation Between Nitroglycerin-Induced Headaches and Coronary Artery Disease. The goal of our study is to see if lack of a headache following nitroglycerin administration is predictive of the level of coronary artery disease. A little bit of background. So nitroglycerin, before it was kind of thought that nitroglycerin would act in an endothelium-independent manner, meaning that the level of atherosclerotic burden would not have an effect on vasodilation caused by nitric oxide. However, more recent studies are suggesting that it does act in an endothelium-dependent manner. So a little bit of background for our study. Nitroglycerin is known to cause headache, and it does that by dilating your cerebral arteries. It's a common side effect seen with nitroglycerin administration. Our hypothesis is that those with coronary artery disease or atherosclerotic burden in the heart would be less likely to experience a headache following nitroglycerin administration, which is dependent on that cerebral artery dilation.
So then we investigated whether the presence or absence of a headache within 10 minutes of nitroglycerin administration would be indicative of the coronary artery status in the patient. And again, as that hypothesis, looking to see if occlusive CAD, more than 50% stenosis, if they experience fewer headaches following the nitroglycerin administration than those without occlusive CAD.
Yeah, so the hypothesis being that if you have atherosclerosis within your heart, you probably have diffuse atherosclerotic burden in your cerebral arteries as well, meaning that when you are given nitroglycerin, you're less likely to experience vasodilation, which would cause that headache. So the way that we set up this study was we enrolled patients in a university medical center when they were coming into the ED. We abstracted information from the chart on factors such as gender, race, hypertension, hyperlipidemia. and then asked questionnaires to patients on the quality and quantity of their headaches. The way we assessed atherosclerotic burden was through echocardiographs, catheterizations, Lexi scans, angiograms, and catheterization and angiogram being the gold standard of whether or not somebody has atherosclerosis. And a total of 29 patients were enrolled in our study.
And lo and behold, with the pie charts that we ended up making, we found some interesting results where those that were not diagnosed with occlusive CAD, they got the nitroglycerin side effects where they ended up getting the headache, as you can see in the red portion, in those that actually got the headache. But in those that were diagnosed with occlusive CAD, suggesting a whole body atherosclerotic burden, those people actually did not get a headache, and the more of them did not get the headache, suggesting that maybe their cerebral arteries were a little less likely to vasodilate and cause those side effects.
Yeah, so when we analyzed this data, we found that that overall association was borderline significant with a p-value of 0.057. When we teased out the data that we did have, we did find significant findings for those who are females, presence of Caucasian race, as well as diabetic patients and those with a smoking history. So the conclusions that we can draw from the study is that although borderline significant, it seems that lack of headache following nitroglycerin administration may be predictive of the level of coronary artery disease in certain populations.
And as far as future aims go, in the future, we could grab a bigger sample size, go to bigger institutions, maybe look at what factors beta blockers, calcium channel blockers would have, other medications, and maybe down the road, this could even speed up the time before a patient would have to get to the cath lab, because if we know the atherosclerotic burden exists, we wouldn't necessarily need to waste as much time in the ED, and we could get them the treatment they need more quickly. So a quick, simple little study, but yeah, but there it is.
Yeah, thank you very much.